Go with me on a journey into your memory banks and recall a moment in your life when you were experiencing extreme physical pain. At that moment, what did you want? Where did you go for help? How did you act? In retrospect, are you proud of the way you responded to that moment of physical agony? In March 2000, I was standing outside of a small exam room on the campus of my medical school in the Bronx, New York. I was about to undergo the final step in the United States medical licensing exam. If I passed this exam, I would be a medical doctor. I had been taught in my training that to be successful, I needed to take a careful medical history, perform a thorough physical exam, and show a bedside manner of compassion and kindness. And so I walked into the exam room. I saw a middle-aged man holding his flank, leaning over a bed, and writhing in pain. "Doctor! Oh, doctor, please, something for the pain! Oh, please, doctor!" I was flabbergasted. Is this when I go over and start asking him about his medical history? "Doctor, oh, it's killing me, please, just something for the pain!" Is this when I go and start examining him? Am I going to fail this exam? At that moment, I made a decision. I asked the nurse in the room to start an intravenous line, and I ordered her to give the patient 2 milligrams of a powerful narcotic pain medication called morphine. It had no effect. I increased the dose to 4 milligrams, then 6, then 8. Finally, after 10 milligrams of IV morphine, the patient was able to relax. He laid down on the bed. I was able to take a history, perform an exam, and diagnose him with kidney stones. I received extremely positive feedback for my performance on that exam. And from that, I learned that acute pain is to be treated aggressively and with strong medications. A few years later, I was a doctor in the United States Army, stationed on the airfield at Bagram, Afghanistan. I was going into a nighttime shift in the emergency department. And as I walked through the doors, one of the nurses told me about a 15-year-old Afghani young man who had been admitted to the hospital earlier that day. This boy lived in a village 30 kilometers from our airbase. He had been climbing a tree to get firewood for his family, and he had fallen from that tree 4 meters, landing awkwardly on his left leg and breaking it badly. He knew that if he was going to survive, he couldn't stay in his village. And so he formed himself a homemade crutch, and he walked the 30 kilometers to our airbase. The most amazing thing about this story is that there is a 3,000-meter mountain range between his village and our airbase. This young man, by himself, traversed that mountain range with a homemade crutch, dragging his broken leg behind him. And when he arrived at the gates of our airbase, he was not screaming in pain. He wasn't begging for narcotic pain medications. He simply wanted a modern hospital and doctors who could fix his leg. A few months ago, I was working at the Howrah Hospital in Taranaki, New Zealand. It was a midday shift, and a call came over the radio from our ambulance crew. They were bringing us a farmer who had been severely injured by his bull. My colleague, who was working the shift with me, said, "Oh, that's interesting. Yesterday, I took care of an 80-year-old farmer who had been gored in his right calf by his bull. I actually wanted to admit that guy because I was concerned about pain control and the possibility of infection in the wound. But he told me, 'No way, doc, I got too much work to do.' And he left." About then, the ambulance crew came through the door with our patient. He was an 80-year-old farmer. We'll call him Graham. As my colleague saw them come through the door, he began to chuckle. "It's the same guy!" I walked over to Graham's bedside. This time, he'd gone back to his farm, back into the same paddock with the same bull. But this time, the bull had tossed him 3 times, crushing his right chest, breaking 4 ribs, bruising his right lung. and completely tearing open his left lower leg so that we could see every muscle, tendon, and vessel in that leg. As I walked up to Graham's bedside, he looked like he was in severe pain, and I offered to give him something for that pain. He looked up at me and said, "She'll be right, Doc. It isn't pain, it's just sore." For the next 2 hours, as we stabilized Graham's injuries and prepared to send him to a larger hospital for definitive care, we continued to offer him powerful pain medications, and he continued to refuse them, accepting only paracetamol and ibuprofen for his pain. From these 3 experiences, I have learned that acute physical pain is an almost universal part of the human experience. But our response to that pain is an individual choice. 16 years ago, when my medical career began, the United States had just introduced 2 new policies into their medical system. The first of these is called pain as the 5th vital sign. This policy requires a doctor or a nurse to take the vital signs of a patient each time they see them, and as a part of those vital signs, to record a pain score. As doctors, we've used vital signs for decades to help us evaluate our patients. We use the vital signs of pulse, blood pressure, oxygen saturation in the blood, and respiratory rate. We have precise instruments that give us objective numbers for these vital signs. When a vital sign is abnormal, it means that the patient may require urgent medical attention and might even be critically ill. The problem with pain as the 5th vital sign is that there is no way to objectively measure a patient's pain. In fact, pain isn't a vital sign. It's a symptom. And the only way that we can get a number for a patient's pain is to ask the patient to give us that number. With the initiative to make pain the 5th vital sign, visual analog scales, similar to the one shown here, allow us to ask a patient what their pain score is and assign a number to their pain. The policy mandates that we get an initial pain level, that we act aggressively to treat that pain, and that we prove that we have successfully treated the pain by asking the patient for another pain score using this visual analog scale. At about the same time, another policy was introduced in the medical system of the United States. This policy had to do with the interaction of doctors and patients. Leaders in the American medical system wanted patients to take more ownership, have more responsibility, and more control over their health care. And so they introduced patient satisfaction scores into the healthcare environment. Each time after a patient-doctor interaction takes place, the patient will be given a survey to rate that interaction. Their responses to that survey are translated into a score, basically a grade for the doctor and the healthcare facility. These scores have come to be called Press-Ganey scores. Over the past decade, Press-Ganey scores have become one of the most important measuring sticks used by the United States government and other major payers in the U.S. health system to determine the quality and value of healthcare. Press-Ganey scores affect physician incomes. In my field of emergency medicine, 5% of my annual income is tied directly to my Press-Ganey scores. Press-Ganey scores affect reimbursement to hospitals. Press-Ganey scores affect the ability for career advancement. If I want to become a clinical leader, I know that my Press-Ganey scores will be evaluated in the process. And so, American doctors are very motivated to have satisfied patients and high Press-Ganey scores. With pain as the 5th vital sign and the pressure on to have satisfied patients, American physicians find themselves between a rock and a hard place. The rock is our sincere desire to satisfy our patients and to address their pain appropriately. The hard place is that the best and safest medical care does not always mean immediate or complete relief of pain. For many patients in pain, the best and safest treatment is simply the tincture of time. For others, it may include repetitive and painful physical therapy. For still others in pain, it requires lifestyle changes, such as a change in diet or increased exercise. Pain is a complex symptom. It not only has to do with physical abnormalities, but it also is affected by the psychological and emotional state of the patient. In order to treat pain correctly, we have to take all these factors into consideration, and the treatment is as complex as the person. We have to decide what we're going to do as physicians in the United States. We want to have high Press-Ganey scores, and yet we're talking about modern America. And in modern America, as has been illustrated by the recent political campaigns, many people don't have patience for complex issues. We want simple answers, and we want them now. Don't tell us we have to wait in pain. Don't tell us to change our lifestyles. We want a quick fix, and if you won't give it to us, we'll go somewhere else to get it. Faced with this culture of convenience and entitlement, many doctors, including myself, opt for the easy road. And that road is the prescription of powerful narcotic pain pills for treatment of all kinds of pain. Narcotic pain pills, or opioids, go by many different names: Sevrodol, Oxycodone, Hydrocodone, Percocet, Vicodin. As American doctors have prescribed more and more of these drugs for less and less severe causes of pain, the sales and consumption of these medications has skyrocketed. In 2011, the number one prescription medicine given out in the United States was hydrocodone, the narcotic ingredient in Vicodin tablets. It was prescribed more often that year than even the most common blood pressure tablet. Medications like hydrocodone have a powerful ability to control patients' pain when they are first prescribed. But these medications also have a deadly dark side. As these medications act on a patient's brain and body to blunt the sensation of pain, they also act on the brain to decrease the patient's drive to breathe. This side effect is exacerbated or magnified when these medications are used with alcohol or other sedative substances, such as sleeping pills. And so all too often, a patient in pain takes a few of the pain pills, maybe a drink or two of alcohol, relaxes, goes to sleep, stops breathing, and never wakes up, drowning in their own mucus. Because of these medications and the increased number, the exponential rise in the prescription of these medications in America, there has been also an exponential rise in the death toll from accidental overdose on these same medications. Every 19 minutes, slightly longer than it's taking me to give this talk, one American dies from taking too many of their pain pills. For the last 4 years, accidental overdose on narcotic pain pills has been the leading cause of accidental death in America. More Americans have died in that period from overdosing on narcotics than in car accidents. We're talking about tens of thousands of deaths each year. And so America finds itself in the throes of the opioid epidemic. The Centers for Disease Control has called this the gravest and most serious health threat ever to face the American public. Now, 3 years ago, I moved here to New Zealand and began practicing medicine in this country full-time. I immediately noticed a major difference between my Kiwi patients and those that I had taken care of in the United States. It wasn't the diseases or the injuries. They are almost exactly the same in this country and in the United States. But my Kiwi patients never ask me for narcotic pain pills. Very few of them came to me already taking those medications. In 3 years here, I have prescribed 12 times the drug oxycodone, or its equivalent. 12 times in 3 years. The last time I worked in the United States, I gave out that many prescriptions of oxycodone in 3 shifts. 3 years versus 3 shifts. I began to wonder, are Kiwi humans a different breed of human? I don't think so. But I do think there is a culture of toughness and of patience and some policies in place in this country governing the use of these medications that keep this country strong and could help this nation avoid its own opioid epidemic. The first example is just mechanics. For most medications here in New Zealand and for all medications in the United States, I can give those prescriptions by using a computer. It takes me a few taps on the keyboard, a printer, and 30 seconds of my time. But here in New Zealand, these narcotic pain pills must be prescribed using a triplicate handwritten prescription form. In a busy emergency department, in order to write for one of these medications, I have to go and find a nurse. Together, we have to go to an electronic locked box. Using thumbprints, fingerprints, and passwords, we open that box. We get out a stack of these triplicate prescription forms. We count through the stack. One of them is removed. We put the rest back in the box and enter an electronic log. I then take that prescription form, sit down, and write the patient's name, their address, their birth date, and the prescription on the form. If I make a mistake, I have to start the whole process over again. As you can imagine, on average, this takes me about 10 minutes each time I want to write for one of these medications. Unless a patient is in extreme pain, I choose not to write for these medications. Hence, 12 prescriptions in 3 years. In the United States, when it only takes me 30 seconds, I can give these meds out like candy. Another example is the relationship between doctors and nurses. In the United States, when I write for a medication, it is the obligation of the nurse, and they are legally liable to follow my order precisely. Here in New Zealand, I will often see a patient in pain. I'll write for 5 milligrams of IV morphine. I'll go back a couple of hours later and find that the patient has only received 1 or maybe 2 milligrams of that morphine. The nurse explains to me that as she continued to evaluate the patient, they told her that their pain was controlled with only 1 or 2 milligrams and no more was needed. There is a culture of toughness and patience in this country. Maybe it's the rugby mindset, where you never want to let your opponent see that you're in pain. Maybe it's the small man syndrome, where a relatively small nation in a very big world wants to show how tough it is. Maybe it's the connection to nature, where Kiwis seem to understand that nature cannot be cheated and that it won't be rushed, and that often the natural way is the best way. I don't know what makes Kiwis so tough, but I can tell you that with the introduction of pain as the 5th vital sign, triplicate prescription forms were done away with in the United States. And that has led to the opioid epidemic in that country. In this country, if Kiwis will maintain their culture of toughness and patience, and if we will support policies like the ones I've mentioned that control the use of these medications, I believe this country can avoid its own opioid epidemic. As I conclude, please remember, acute physical pain is an almost universal part of the human experience. But our response to that pain is an individual choice. America has proven that the overtreatment of pain is more dangerous and deadly than pain itself. And certain policies in this nation and the Kiwi culture of toughness and patience can help New Zealand avoid its own opioid epidemic. Thank you.